Let's talk about Horners. Meiosis, ptosis and hydrosis. This we are studying since times immemorial. But I want to add few more things. In the name of Horner syndrome, you should understand the entire pathway and a little bit of pharmacology also. If you look at the eye, the pupil constricts or dilates. Why does it do? It is the iris which is responsible. It is the iris. So you have sphincter pupillae, dilator pupillae. They are the ones which basically decide whether the pupil is going to constrict or not. If you take sympathetic fibers, they go and innervate the dilator pupillae. And if the sympathetic release is there, dilator pupillae contract and then that dilates the pupil. Parasympathetic oculomotor nerve will carry the fibers and supply sphincter pupillae. That's the reason it leads to pupillary constriction. Now, how is this sympathetic pathway? It is a 3-neuron pathway which starts at the level of hypothalamus in the brain. From there it will come to medulla and it will go into spinal cord, and from here it will reach the internal carotid artery. And at the level of the internal carotid artery, it will touch a place called superior cervical ganglion. From here the fibers will start and then they ultimately reach the dilator pupillae. Now let us look into it. It caudally descends from the hypothalamus to the first synapse, which is located in the cervical spinal cord at the level of C8T1, at that level. So this is until this point, that is from hypothalamus through the medulla until it reaches this C8T1 level, you call it as the first order neuron of the sympathetic path. Now, from the level of the C8T1, you know that brachial plexus originates from C5, C6, C7, C8, T1. So along with the brachial plexus it will go to the school. Because by the time it reached C8, T1, one more child is born. So along with the brother it will go to school. Who is that brother? Brachial plexus. Then while going to school, there is a garden, it will go above the mountain and then it will be going. And where is that mountain? Apex of the lung. Any Pancoast tumor there. While going to school, gardener will be threatening, don't pluck the roses. But we pluck the rose and go to the school because we want to impress the most beautiful teacher in the LKG class. So the Pancoast tumor can compress it. Then it will be ascending from the apex of the lung to reach the superior cervical ganglion, which is located at the angle of the mandible at the point of the bifurcation of the common carotid artery into internal and external carotid artery. So till that point of superior cervical ganglion, from the thoracic cord, T1 level, it's called second order. Then it will be crawling through the internal carotid arteries wall and it will be passing closer to the cavernous sinus, and here it is in a very close relation with the sixth cranial nerve, and after crawling there it will be reaching the ophthalmic division of the fifth cranial nerve, because finally its journey is towards the eye. And in the orbit it will be typically finally reaching the dilator pupillae of the iris and then dilate the pupil. In addition to that, these fibers, sympathetic fibers, will also innervate one muscle called as Muller's muscle, which is responsible for elevating the eyelid. Eyelid is mainly elevated by levator palpebral superioris. Additionally, Muller's muscle is also there. It is like big mechanic, small mechanic. Chotu is Muller, Bada mechanic is your levator palpebral superioris. So if the Muller's muscle got paralyzed, if the sympathetic innervation is interrupted, what will happen? There is a ptosis, and enophthalmos, that is, eye will look as such, it is being sunken back, drawn back, small eye is what will happen, because sympathetic fibers finally supply dilator pupillae and also the Muller's muscle is what we have to basically remember. Now, let us look what happens if you take a person into dark room. Normally, in the dark, what will happen? The pupils dilate. Now, if you take the eye into the dark room, normal pupils, both of them will dilate equally. If you put back the light, once more they constrict. But in case of the Horner's eye, there is a lid is drooped and the pupil is unable to dilate, whereas the other pupil, which is normal, already dilated. So this kind of difference in the size of the pupils is called as anisocoria, right? So when we go into darkness, normally sympathetic innervation will discharge and that will cause the dilatation of the pupil, but this Horner's eye pupil, since sympathetic interruption is there, the pupil doesn't dilate, the other pupil will dilate, hence there is a development of anisocoria. Common way of asking this question in the entrance is, a person whose pupils are of a same size when he is looking in the daylight was taken into dark room, then the anisocoria developed. Why pupils are of the same size when a Horner's patient is looking in the daylight? Because when you look into daylight, your pupils constrict, and constriction of the pupil is because of parasympathetic innervation. Parasympathetic innervation is normal in Horner's, hence both the pupils will constrict. Magar kab pata chalega whether it is a donkey or a horse? You take it into dark light, then the sympathetic innervation is missing in the Horner's eye, so pupil remains small, but the other pupil will dilate. So this degree of anisocoria, which is marked in the darkness, is the feature of the Horner syndrome. Now, ptosis is a very mild ptosis. It's also called as upside down ptosis. Clonidine, instillation of clonidine will make us to diagnose the Horner's. First, we should know what will clonidine do, what is the normal function of the clonidine. But before talking about clonidine, let us look at the pupils. If you look at the pupil, typically there is a meiosis in a pupil which is having Horner's. Other pupil size is slightly bigger. After you have put aproclonidine in both, the pupil of the Horner will dilate, whereas the other pupil will typically remain of the same size. So earlier the dilate relatively, which is a bigger one, normal eye, will then become bigger in the Horner's eye. Pupil become bigger in the Horner's eye. So what is this also called as? Reversal of anisocoria on instillation of clonidine is what you see with the Horner syndrome. Now the question comes, why with clonidine instillation the anisocoria is reversing in Horner's? They are debating about it. First, doctor, in pharmacology you should know the adrenergic receptors are of three kinds: alpha 1, alpha 2, beta 1, beta 2. So if the adrenaline acts on the alpha 1, then smooth muscle will contract. Even in alpha 2 also smooth muscle will undergo contraction. But if it acts on the beta 2 receptor, smooth muscle will relax. Where are the beta 2 receptors are located in our bronchi? Hence in asthma we give the sympathomimetic agent so that the beta 2 receptors will stimulate, and that will lead to smooth muscle relaxation, bronchus will dilate. Agreed, doc? Now alpha 1 or alpha 2 should lead to smooth muscle contraction. Now in which location do you have these alpha receptors? We have these alpha receptors on the dilated muscle of the iris, and if you stimulate this alpha receptor, the dilated muscle will cause the dilatation of the pupil. But listening to this you will say, "Re, kya baat hai sir? Pupil will dilate if the alpha 1 receptors are stimulated. By what? The sympathetic discharge. But in case of Horner's, there is no sympathetic discharge, because there is a sympathetic system innervation. I mean, denervation is there, block is there. Then why the pupils are getting dilated if you stimulate alpha 1 is the question. Now let's come to that point. If you look at the apraclonidine, it is a selective alpha 2 agonist with only a weak alpha 1 action. Weak alpha 1. It is not alpha 1 agonist, it is alpha 2 agonist actually. It has got only weak alpha 1 action. इसलिए अगर एप्रक्लोनिडिन को इंस्टॉल करे तो नॉर्मल आई में, will normal eye dilate? It should not. Why? Because apraclonidine is after all a weak alpha 1 agonist, and alpha 1 receptors are there on the dilator pupillae. That's the reason it won't. I mean, it won't mean slightly, it will cause the dilatation. But if you are having a Horner syndrome, what is the problem? The sympathetic innervation to the dilator pupillae muscle, it got interrupted. अगर वो interrupt हो गए तो what is happening? Epinephrine normally which is released and which will cause the pupil to dilate, it is not getting released regularly. अगर regularly receive नहीं, if it is not released regularly, those receptors which are located on the dilator pupillae are there, no? They increased in number. क्यों? अगर थोड़ा मिल गए तो भी we wanted to use it. It will be thirsty. अगर थोड़ा मिल गए तो भी I want to use it. And this kind of increasing receptors as a consequence of denervation is called as denervation hypersensitivity. In this situation, if you drop clonidine, though it has a weak alpha 1 agonistic activity, all the too many receptors will immediately receive it and dilate the pupil. And the pupil will dilate more than the normal eye. That's the point. It's like if you are studying in purely boys college, no girls in the class at all. Suddenly the next Stephens College girl happened to come even to tie Rakhi also. There will be a huge crowd because you are suffering from denervation hypersensitivity. That's what happened. Apraclonidine is the Stephens College girl came to give tie Rakhi. So you don't want to know whether she came to tie Rakhi or want to give a Valentine invitation card or whatever it is. But you are starved and denervation hypersensitivity is there. Got me, doctor? So tell me, apraclonidine, what it does? It is alpha 2 agonist. It has no alpha, it has mild alpha 1 action. But in the wake of the denervation hypersensitivity and more number of receptors on the iris, dilator pupillae, even that little alpha 1 activity will cause an immense dilation activity, and there is a reversal of the pupillary dilatation and anisocoria if you instill it, because the other normal eye with normal receptors with the mild action of apraclonidine has no effect of it, is what you need to understand. Now the next important issue, this is what will happen. See, we are instilling the apraclonidine. aproclinidin. Initially, this is the Horner's eye. You can identify by a drooping eyelid with a smaller pupil. Now, once you instill the aproclinidin, typically the earlier smaller pupil now became a bigger pupil, and reversal of anisocoria is there, is what need to be remembered. There is one more important test called cocaine test. What it will do? If you put cocaine eye drops, what they will do? They will block the reuptake of norepinephrine. See, doctor, these are the dilator pupillae. This is the sympathetic nerve third order neuron ending, and it basically releases the norepinephrine, and the norepinephrine acts on the dilator pupillae. Then once more this norepinephrine, the synaptic junction will be taken back by the third order neuron, and once more it become released. Now what is cocaine doing is it is blocking this norepinephrine reuptake. And what will happen if you happen to drop this 10% cocaine is an important question. Before 10% cocaine instillation, what is the situation of the Horner's pupil? It's myosed. Why it is myosed? Because the third order neuron is unable to bring enough norepinephrine. That's the reason. But if you happen to drop the cocaine in a normal eye, what will happen? The pupil become more dilated. Why? Because the norepinephrine which is there in the neurosynaptic junction is not been reuptaken, so it remained in the synaptic junction. It continued to stimulate dilator pupillae and pupil dilates. But suppose if there is a Horner, there is no norepinephrine at all, and what is that leading to? If there is some norepinephrine, if its reuptake is inhibited, then dilatory effect of the cocaine can happen. But in this case, since there is no norepinephrine at all, even if you put cocaine, there is no mydriasis happening. That's how you will basically identify. There is a mydriatic failure if you happen to instill the cocaine. Now let us see typically how a cocaine test look like. So this is a typical Horner's eye. After you have instilled, the other eye dilated. There is a mydriasis happening after cocaine instillation. Whereas the Horner's remained horning only without any further dilatation. That's what we need to understand. Then you have one more test. Amphetamine test. What does it do? Basically it will be able to localize where is the lesion in case of the Horner's. Now what does amphetamine basically will be doing? Amphetamine will be making the norepinephrine stored in the synaptic vesicles to get discharged. So if you happen to administer or instill amphetamine, then this norepinephrine become released and it will cause a robust pupillary dilatation. Suppose if the lesion is proximal, that is first order neuron or second order neuron, how is the third order neuron? Third order neuron is intact. That means at the level of the synaptic presynaptic membrane there are vesicles, in that there is an norepinephrine, but since first order and second order neurons are not giving a signal, the third order neuron is unable to discharge. But if you put amphetamine, it can discharge and cause pupillary dilatation. But if there is a degeneration of the third order neuron, then there are no synaptic vesicles only. And hence, if you instill amphetamine, there will be no mydriasis. So amphetamine instillation will help you to localize. If amphetamine instillation is causing mydriasis ka matlab, first and second order neurons are problematic, third order neuron is intact. And if after putting amphetamine, if there is no mydriasis, that means third order neuron is basically problematic. So summarize, doctor, the whole story. The future NEET 2013, 14, 15 are going to have this kind of an illustration. I instilled something in the eyes, it happened like this diagram, after that I instilled something else and this became like this. Tell me what I instilled at these three levels, or if I tell you what I instilled, can you tell where is the lesion? So summarize, doctor, if you put cocaine, there is a reversal of mydriasis. Sorry, if you put aproclonidine, there is a reversal of mydriasis. If you put cocaine, there is no change. There is no change. It remains the same. In fact, the anisocoria will increase because the other pupil will dilate more. Then if you put amphetamine, if it is a post-ganglionic Horner's, that is third order neuron is degenerated, then there will be no response. But if it is preganglionic Horner's with the third order neuron intact, then the dilatation will typically happen. So that's how you basically differentiate. Then you also have anhidrosis, lack of sweating, and it is present in only preganglionic lesions. Why? Because in its journey from where it is coming, from hypothalamus, it is coming to the supracervical ganglion. At this level the fibers are given, which will cause the sweating to get stimulated. So only if the lesion is there at this level, then only these fibers are interrupted. If the lesion is more distal, then these fibers are intact. So anhidrosis localizes the lesion to more proximal location, is what we have to fundamentally appreciate. And those who have a congenital Horner's, they have an associated heterochromia also, unequal iris color. What is the reason? If you go back to anatomy, the melanocytes, that is the pigmenting cells, the sympathetic nervous system development, everything will occur from one common place, neural crest cells. Any problem there will cause a sympathetic problem, Horner's, along with that depigmentation of the iris. Hence, there is associated anisocoria along with the Horner's is what we need to basically appreciate. So, what are the various causes for the development of Horner's? You should remember hypothalamus se medulla, medulla se thoracic cord se supracervical ganglion, and from there until the eye. Anywhere the problem can be there. So first order neurons, where can they be interrupted? If there is any lesion in the brainstem or the cervico-thoracic spinal cord, it can cause first order Horner's. One of the classical example is lateral medullary syndrome. If you look at the lateral medulla cut section, morning you might have reviewed different syndromes. Typically in the lateral part of the medulla, the sympathetic chain will be passing while it is traveling from hypothalamus towards medulla towards thoracic cord. So there, or any syringomyelia. Suppose if the central canal of the spinal cord got dilated, it can compress the cervicothoracic sympathetic fibers. Then second order, that is before it goes and merges at the level of the superior cervical ganglion, any apical part of the lung cancer, pancreas tumor, or any lumbar epidural anesthesia, any of them can cause. Then finally, once it is traveling on the fence of the internal carotid artery and going through the fifth cranial nerve into the eye, then any internal carotid artery dissection or cavernous sinus lesions can lead to the development of the sympathetic nerve. Involvement is what we need to fundamentally appreciate. So doctor, this revises how amphetamine works, how cocaine works. So many other facts have come out between preganglionic, postganglionic anatomy of the sympathetic chain. Now let us talk about congenital myopathies. Once more, this is also not a undergraduate level topic, but anyway, this is a typical patient of a congenital myopathy. They'll have the onset at birth with decreased muscle tone and very slowly progressive or non-progressive, and they will have a longer survival. That's what you see with congenital myopathies. They are in turn divided into central core, nemaline, centronuclear, so many different kinds of congenital myopathies. There are secondary causes for the development of myopathy. This is important. In everyday, day in and day out clinical practice, you have hypothyroid patients with proximal muscle weakness, diabetic patients with proximal muscle weakness. So thyrotoxicosis, Cushing syndrome, acromegaly, and paraneoplastic disorders with myopathy, they're all acquired causes of the myopathy. Now AIMS November 2010 question is, a girl aged 20 years complains of headache while studying. Reasonable. Her vision is found to be normal. What you don't want to inquire to evaluate her headache. Really there are not many of gynecological causes for the headache. Menstrual history is not really expected, but yes, family history, of course there's a catamenial epilepsy, that's a different story, but family history of headache, self-expectation, her interest in the study is most important. Generally if we are bored in the reading room, doctor, we are reading generally what is not necessary, remember. We are bored about the God when we go to temple means we have some other thing, purpose in the mind and gone to the temple. So that is the reason. It is that because medicine is very dynamic subject. It's not static. It's not like zoology or botany. It is human beings who are around us. We are treating every day. We see all these conditions depending upon the specialization you do. So that's the reason they're all live cases. So you need to look whether there is any depression in this headache. Yes, psychosomatic disorders can present with the headache is what need to be remembered. A young male presents to the casualty with a thunderclap headache, which is of sudden onset, with undilated, unilateral dilated pupil. What is the cause? Always remember, I never had this much a severe headache, doctor, never in my life. If somebody says, it should be thought as subarachnoid hemorrhage. Ruptured aneurysm is the most common cause. There can be sometimes sudden loss of consciousness that can precede this excruciating headache's onset. And after regaining the consciousness, patient will say, never I had this much a severe kind of a headache. Usually it is a generalized headache, often with the neck stiffness and even vomiting. That's how the presentation of a subarachnoid hemorrhage. And you have taken a CT, non-contrast CT, NCCT is the initial investigation of choice. Then you have what are called Sylvian fissures. They will be full with the blood, which lead to that opacification of the Sylvian fissures. I'll show you one CT. So that's how you basically identify. So one more thing. Where is the bleeding in subarachnoid hemorrhage? It is brain के ऊपर, dura के ऊपर, arachnoid के ऊपर, paya. Or? Good. So it is between pial layer and arachnoid and not directly on the brain, unlike intracerebral hemorrhage. That's the reason it is unlikely that you get hemiplegia or any sort of focal neurological deficits. weakness, aphasia or anything, you don't expect it. But still they can happen in subarachnoid hemorrhage. Why? Because your vessels will be passing through the bleed and going to the brain. And those vessels, because of this surrounding bleed, can undergo spasm and ischemia can occur, which can lead to focal neurological deficit. But subarachnoid hemorrhage per se does not lead to focal neurological deficits. That's the reason what is your most important duty? Give calcium channel blocker. Keep the vessels dilated. Hydrate the patient. Keep the vessels dilated. Don't let the vessels go into spasm. And under your leadership, patient is managed and he develops focal neurological deficits, means you have thoroughly mismanaged the patient. Or maybe his fate is like that, whatever. So, aphasia, ebulia, hemiparesis, none of this will be there. So a sudden headache in the absence of the focal neurological signs is the hallmark of an aneurysmal rupture leading to the development of the subarachnoid hemorrhage is what you need to remember. Now, you have studied anatomy very well, the vascular supply in the morning discussion. So you have what is called as a posterior communicating artery, PC, posterior inferior cerebellar artery, PICA, and posterior communicating artery, anterior communicating artery, which will be connecting the two posterior cerebral arteries and anterior cerebral arteries. So this posterior communicating artery, where the two cerebral arteries, posterior cerebral arteries originated from the basilar artery are connected, can develop an aneurysm. In that area you have the midbrain on the brainstem. You know, brainstem के पीछे basilar artery is there ना, basilar artery पूरा midbrain के पास जाने के बाद दो posterior cerebral artery होगा, उनके बीच में communicating artery है, उसको aneurysm आ गया, and that aneurysm is trying to compress the midbrain. Midbrain में which cranial nerve is there? Third, fourth is midbrain, fifth, sixth, seventh, eighth is in pons, and eighth, ninth, 10th, everything else is in medulla. So this location of the cranial nerve nuclei you should never forget. So third cranial nerve nucleus, that is the oculomotor, is just coming out from that midbrain, and this posterior communicating artery aneurysm will compress it. And obviously when oculomotor nerve is compressed, what will happen? Sphincter pupillae, parasympathetic fibers are no more able to go there, hence only dilated pupillae will be acting unopposed, hence that lead to mydriasis, pupillary dilatation. Okay, doctor? Now here, one point I want to once more reinforce to you. A oculomotor nerve palsy can occur because of two different reasons. Surgical causes like this, where PCOM aneurysm, posterior communicating artery aneurysm, can compress it. Second cause is diabetes, hypertension like conditions, where there can be the vasa nervosum going to the oculomotor nerve can suffer ischemia, and that can cause the oculomotor palsy. They are medical causes, diabetes, hypertension like arteriosclerotic conditions. How to differentiate the two? Typically if the pupil, if you look at the pupillary fibers, they will be passing through the core of the nerve. That's the reason this vasa nervosum ischemia will not affect the parasympathetic fibers passing in the oculomotor nerve. It will only affect the fibers which will go and innervate the extraocular muscles. That's all. Hence, you will have oculomotor palsy, the muscle palsy, but no pupillary dilatation. If it is diabetes or hypertension, which is only affecting the extraocular muscle innervating fibers without affecting the parasympathetic fibers which are passing in the core. Whereas a PCOM aneurysm doesn't know where are the extraocular fibers, where are the parasympathetic fibers. It will compress everything. If a psychotic external examiner is there, he will fail everybody and go. If it is only a psychotic internal examiner, he will be psychotic to only one set of students, not to the others. So, diabetes, hypertension are like the internal examiner who is psychotic. Whereas PCOM is like an external examiner psychotic, failed all students in medicine and gone. So, kind of a situation. So, whether it is surgical cause or medical cause, how will be the eyelid if oculomotor palsy is there? Drooping. मगर वो droop हो गए eyelid को, lift the पर्दा and look at the pupil. अगर pupil dilate हुए तो, what will you do as a house surgeon? Go and call the neurosurgery resident. He will come and he will say, first get a radiology, MRI or CD, and the MRA will show the aneurysm. He is paraded to the interventional radiology or to the neurosurgery and surgical repair is done. मगर पर्दे को उठाओ, eyelid, and check, pupil is normal. Then whom do you call? Nobody you will call. Exercise karo bhai, glycemic control karo, BP control karo, because medical causes are responsible, is what you will basically tell. So, PCOM, midbrain, oculomotor nerve, you need to remember the relationship between one another. Now, the sixth nerve palsy, can there be any aneurysm which can compress it? Yes. Cavernous sinus aneurysm can compress sixth nerve. And if there is any carotid or anterocerebral artery, the aneurysm of it can compress the optic nerve and can lead to development of visual field defects. Then there is a posterior inferior cerebellar artery or anterior inferior cerebellar artery. Their aneurysms can cause the posterior and posterior cervical pain and the occipital pain. So, any vessel in the brain can have aneurysm, it can compress anything. We are very feeble structure as a human being. We don't know when which aneurysm is there, so don't get unnecessary MRIs. अगर शादी के पहले MRI हो गया और सबको मालूम हो गया कि एक aneurysm है, there will be nobody who will be courageous to give a girl. So be very sure to don't get unnecessary. If we get aneurysm, MRI done, one or the other of us will be definitely having an aneurysm. So, around the temple, if there is any pain or periorbital, it can be because of a expanding MCA aneurysm. I know next time when you get headache, you will be thinking of occipital height of O aneurysm, eye ke paas ye aneurysm, finally pupil, how it is, you will be looking in mirror. So, it is the non-contrast CT. Where you can identify the subarachnoid hemorrhage. Actually, in a different cut in this area, you will have what are called Sylvian fissures. In Sylvian fissures, if there is a filling of the blood, that means subarachnoid space mein blood is there. That is the how. Then you can do a MRI FLAIR image. What is meant by FLAIR? Fluid attenuation image. That means bony structures ko sabko nikal ke purely parenchyma of the brain mein edema kaisa hai. If you want to know, FLAIR image is the best option. After 48 hours of onset, you can do a FLAIR image. Now, what are the complications of subarachnoid hemorrhage? It can lead to re-rupture. That is the biggest threat. एक बार आ गया, थोड़ा bleeding हो गया, बच के बाहर आ गए, but we don't know when it will re-rupture. It can lead to hydrocephalus due to the blood in the subarachnoid space. It can undergo vasospasm, focal neurological deficits can develop. And it can lead to hyponatremia. Why hyponatremia will develop in subarachnoid hemorrhage? Whenever the brain suffers any injury, typically it will lead to the release of the atrial natriuretic peptide, brain's atrial natriuretic peptide, which in turn will lead to natriuresis, and that typically lead to the development of hyponatremia, is one of the dyselectrolytemia complication in subarachnoid hemorrhage patients. But when you are clinically managing the patients, imagine the combination of all these situations. You have a subarachnoid hemorrhage patient, he is drowsy. What are the differential diagnoses? He may be drowsy because of the hyponatremia. He may be drowsy because of the vasospasm of the vessels, which is leading to probably altered sensorium. He is going into coma maybe. Or there might have been a rupture of, one more bigger rupture of the aneurysm, which is causing more severe bleeding. So you need to identify what is the possible underlying reason for the development of the drowsiness in a patient of subarachnoid hemorrhage. So how do you treat it? If you are a neurosurgeon, you will operate, identify that and clip it. If you are a endovascular surgeon or interventional radiologist, tuck, 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 you will reach through a wire. And there you will put a coil. And the coil will fill it. There is no blood in that, but coil. Coil won't rupture. If it blood hai to rupture hota. So that is the idea of placing it. But overall, what is the reason you are worried about subarachnoid hemorrhage? Headache hai na? Headache to kam ho gaya na? Then why do you worry? It may undergo vasospasm and lead to focal neurological deficit. That's the reason I am worried. Vasospasm is the major problem. How do you prevent it? You can give calcium channel antagonist nimodipine, which will improve the prognosis. And the treatment is called triple H. Induce hypertension, induce hemodilution, induce hypervolemic therapy. So you will be giving the IV fluids to improve the plasma volume expansion, so that you will increase the mean arterial pressure and improve the blood flow. And that is the most important thing to prevent the vasospasm and the focal neurological deficits. So triple H, give fluids, hypervolemic therapy, dilute the blood so that it will prevent the rise of hematocrit and vasospasm, and induce the hypertension by increasing plasma volume. So that is what you need to basically do. So volume expansion prevents the hypertension, it will increase the cardiac output, it will reduce the blood viscosity, and it will prevent the vasospasm is what you have to fundamentally appreciate.